Here we are so happy. This is our third lunchtime learning for this year, and today we have Emily Padula. We're very thankful to have her, and I am old enough that no one had got a degree in innovation, and definitely not healthcare innovation. But Emily has her master's in healthcare innovation. She also has her BSN as well as her RN. She is our Chief Strategy Officer, and she's been here since 2011. She is responsible, which I think is very exciting. Her responsibilities include stewarding our vision of healthy community, as well as overseeing several departments and leading transformation across the care continuum. And she has actually served in other places for over 14 years, so she is probably a little older than she looks, you know? So we love that. She's very young looking. So anyway, she's very advanced for her young age. But anyway, come on up, Emily, and please tell us what's happening with healthcare. We are anxious to learn.
Okay. Well, thank you for coming today. I am honored to be able to talk with you all, particularly you that volunteer. Thank you for your service to us. When we look at our contributions throughout the year from our foundation, all those wonderful people in our community, what we find is that the majority of our contributions come from volunteer hours. The majority of what we receive is through you, so thank you for doing that. And then to my team members, great to see you all here. I think I know just about, I just don't know you, I don't think. Are you a volunteer?
Woody.
Yes.
Okay.
He's with hospice.
Oh, well, nice to meet you. Okay, so what I will be covering today is about healthcare payment changes. I was freezing when I came in here, so I turned it up, so if it gets too warm, can you guys manage that? Thank you. And there are some payment program changes, and I use the word threats because when we look at a SWOT analysis or kind of strategic planning thinking, we think about what are the strategic strengths, weaknesses, opportunities, and threats. And when we look external to us, we say, what are those things out there that are threats to our organization, to our community's healthcare, and then what are the opportunities that arise out of that? So that's how I'll organize this presentation, starting with the threats, and then moving into the opportunities that we see ahead. So healthcare payment is changing. This is a historic time for healthcare payment. Probably equal to about, if any of you remember the 80s when there was a lot of change in HMOs and payment changes, Medicare starting, those kinds of landmark times in healthcare's history. This is another one of those. Medicare has announced that they're going to change how they pay so that by the end of 2018, 50% of payments will be alternative payment models. So that means half of what Medicare spends will be using a risk-based model where they will pay a healthcare provider, like a doctor or a hospital, a certain amount of money, and then that hospital has to do, or that healthcare provider, all the care that that person needs with that amount of money. They don't get more if the person needs more care. And so Medicare has announced that they're transitioning to about 50% that payment model by the end of 2018. The other thing that they're doing, I think the whole 80s thing with HMOs made them nervous about not talking about quality. So there's a lot of talk about quality. And by the end of 2018, they want 90% of their payments to have penalties if people don't have good quality. And the quality payments will be based on whatever half of the healthcare providers are doing the worst in the nation, they'll have to give their penalty money to those providers that are doing the other half that are doing the best. So it's zero sum. So everybody is kind of competing to be better on quality. This has a lot of bipartisan support. I just show this slide to say that 484 members of the House and Senate supported this big bill that came out recently. So regardless of who becomes president going forward, we don't anticipate a lot of changes in what happens here. We think that the way things are the way things they will be. And typically the way Medicare goes, the other insurance companies go within a year or two. So we anticipate Medicare will make these changes by 2018. By 2020, most health insurance companies will do the same thing. So healthcare will look very different in the next decade. So how does that look for us as a hospital? There are already 4 payment programs, penalty programs in place for us as a hospital. We've had them for the last 5 years or so. And they're called value-based purchasing, inpatient quality reporting, hack reduction, and readmission reduction. So the value-based purchasing, it says Medicare will pay you 2% less 2 years from now on every one of your payments if you don't meet all of these certain criteria. And this one is a zero-sum program. So most hospitals, in fact 85% of hospitals will lose money on this program, and 15% will make money. Over the last 5 years, every single year we've made a little bit of money on this program, just a smidge, but we haven't lost any money. And we've had about $1.5 million at risk every year based on our quality for that. And we've made about $80,000. So it's a good thing we didn't lose $1.5 million, but we didn't get rich off of it, and I don't think that's the plan. One of the things that I'm pretty sure is true when they said it was the Affordable Care Act. You know, Obamacare was originally called the Affordable Care Act. I think it was not intended to make healthcare more affordable for us. It was supposed to be more affordable for the federal government. And so that's where you're seeing a lot of these payment cuts. And we hear things, I don't know if you've heard some of the scare stories, but Medicare is going to go bankrupt by 2022. We don't have enough federal dollars to cover the cost of healthcare in the U.S. anymore. Our GDP is rising slower than our healthcare costs, all of that. This is supposed to try and fix that. They're like, we'll just pay healthcare providers less, and then consumers will have to pay more, and maybe that'll fix the rise of healthcare costs. So the second thing is inpatient quality reporting. This one is just basically, we have 2 people who sit in an office downstairs and they spend all day long turning in this quality data, because if we don't, we will get a 2.5% cut. So that's what that program is, and we have to get it in on time, otherwise we get a cut. There's no upside on that one. Then the hack reduction program, this one is one where 25% of all hospitals in the nation will always have a 1% cut to their payment if they have the lowest safety scores. So whatever the lowest 25% safety score is, and that's for things like if you get an infection after surgery, if the doctor nicks a vessel when they're doing surgery and you bleed a little bit more than you should have, or things like that. So whoever has the most of those, the top 25% of those, will always lose 1% of all their Medicare payments for the year.
What does HAC stand for?
Hospital acquired condition. Thanks, JP. Oh yeah, feel free to interact, because otherwise we'll all fall asleep. It's lunchtime and dark and cozy in here now. And then readmission reduction is the last one. And that's for if you go to the hospital, you get admitted, you have something done, and then you have to come back in within 30 days. That is considered a problem, that someone must have done something wrong. And so if you are in the top 30% of the nation for that, you automatically lose 3%. And that'll happen every year. Every hospital that ends up in that top 30% readmission group will lose that much money. So overall, we have about 9% potential downside when you look at everything, and a 1.5% potential upside. So mostly a cost reduction for the federal government on this one for hospitals.
So Emily, to clarify on that hack, for instance, you said 1% of all Medicare payments, so it's not just 1% loss on the hack condition admissions, it's everything we're paid that year?
So, I mean, how do you get out of that? If you're losing X amount per year, I'm not saying that we are. If you do that, don't you have to try like exponentially harder to get out of that? Right?
Yeah.
Like, I mean, it sounds like
With less money.
Right.
Yes.
Right. Okay.
Yeah, good point.
that.
And it does hit 2 years later, so our payments right now are being affected by how we performed in 2014 on all of these indicators.
So some of the things then, we've done a few things like our new zapper, our germ zapper. Tell us about a few of the things that we're putting in place
To address these.
to make sure, even whether we're losing money or not on it, we're thinking ahead.
So for all of these, we have never lost $1 on any of these programs for as long as they've been in place. A great organization with wonderful people doing a great job. And that is not true for the great majority of hospitals. It's probably in the 90% of hospitals category now that are losing money. So value-based purchasing, that one, it looks at patient satisfaction. That's a big portion of that. And our patient satisfaction is in the top 50 in the nation, so that really helps us with our score on there. There's also, HAC is incorporated into this as well, so you get a double whammy on any complications or things going wrong. So we've worked a lot on, we're seeing a resurgence across the nation in C. difficile or C. diff rates, and that's a stomach kind of bug that you can get that can be pretty nasty. And so we're working really hard on infection control across the organization, from hand washing to a robot that we have that by UV light, you roll it into a room and whatever the light touches, it kills the bacteria. And so we've been doing that in our ORs. We're using a new sporicidal cleaner called Oxycide to clean everything. So if you smell vinegar when you're out and about, know that you are protected from C. diff. That's what that kills. Most cleaners don't kill C. diff, only bleach does, and this Oxycide. So we're doing a lot around that. Readmissions, we've been in the top 5% of the nation, the best in the nation on readmissions for many, many years, so due to some great historical work that's happened here. So at this point, we've had a slight creep in that, but that's still going really well. We're still in the top 5% of the nation. We have a care navigation program that calls patients that are at risk for being readmitted and helps them to learn how to check on and make sure that they're not at risk and they're taking all their medicines, they're going into the doctor, things like that. And then making sure that we make appointments for people for their follow-up at the doctor right away when they leave the hospital. And then with quality, I think a strength of this organization is we're constantly looking at our data. Those of you that are team members probably know that, but we know where we stand on all of our measures all the time so that we can stay on top of it, not just for this, more importantly for the sake of our patients, so that we can really be a premier hospital and best in the nation. And neat news is CMS or Medicare announced that they've done their 5-star ratings of hospitals, and there's a lot of controversy because they said it's way too hard to get 5 stars. 3% of all hospitals in the nation ended up with 5 stars, only 102 hospitals out of the 3,000 hospitals that there are. And guess who got 5 stars? So because of the work historically, the work of all of you today, we are well positioned for this to at least not lose money. There's little to be had extra, but we're seeing a lot of healthcare organizations that are not doing so well with this. So we're blessed to be where we are. But there's more coming. So across the care continuum, there's also some reduction programs. Total joint bundling, Marilyn's our expert on that, but basically it looks at joints. So any hip or knee replacements that we do, there's a big cut to that if you don't provide really good care for the 90 days after someone has that surgery done. And so if the nursing home has a problem, if the patient goes home and gets an infection at home, that hits you on, and you get a penalty for that on this program. This has not yet come to our region, but we anticipate it will in the next few years. It's in Austin and San Antonio for sure at this point. Next is home care. Home care is not yet hit. These are not yet hit, but we anticipate in the next couple of years. It'll be, they'll be measured on patient experience and quality in home care and whether patients get better in home care. And the lowest performing home cares will take a 9% hit to all of their Medicare payments for home care. And I would say about 90% of our home care patients are on Medicare. And then if those that perform better will get a small bonus. So it's an up and downside program. Hospice has not yet been defined, but they're developing a program for hospice, which is the same thing. It would be based on patient satisfaction and quality, and whoever is the worst has a 9% penalty, and it's a graduated penalty program based on your performance. And then physical therapy, occupational therapy, speech therapy, same thing, up to a 9% penalty based on where you stand on your performance.
Emily?
Yes.
Since the patient in hospice moves on to another plane, how do they get customer feedback?
It's all family.
It's all family,
Yeah.
okay.
Okay, so what's going to happen to all these healthcare providers that keep falling? I mean, there's going to be fewer of them, and the population is getting older. So where are we going with all this?
Well, there were some studies that showed, and this is slight conspiracy theory, maybe not all fact, but there have been studies called the Dartmouth-Hitchcock studies that showed that basically the more healthcare that's available in a region, the more healthcare people get, which seems fairly obvious to me. But if that specialty is available in your region, you're more likely to get it. So I think there's a sense in which if we're trying to reduce the cost of Medicare across the United States, if there's less healthcare available and you have to go further to get it, people will utilize it a little bit less, which will reduce costs.
Well, the other point of that is if we are requiring people to be more like this hospital in this general area, which truly is a quality program, then maybe the healthcare, even if it's not so many providers, will be better. And then maybe fewer people will have to go back for this, that, and the other.
That is a great cross argument for that. That's really good, thank you. And what we're seeing is there is opportunity for us if other healthcare providers in the region aren't able to be successful. That's something that we can consider how we can provide that healthcare in new and exciting ways to help those communities. So the big news this year was physician practices. So physicians now, individual physicians, physician practices are also going to be placed on a penalty program. And it is called MACRA-MIPS or Quality Payment Program, depending on who you ask. And they're measured on quality. They have to be doing, they have a list of 90 practice improvement activities they can do at their clinic that they have to do at least 3 every year to improve the clinic. Electronic health records, so they have to be utilizing it. Things like what percentage of your prescriptions are done electronically, what percentage of your patients are using a portal, things like that. And then the last is resource use, and what that means is how much did your patients cost Medicare this year? Not just what they paid you for those patients, but were they an expensive patient to Medicare? And if so, then there'll be a penalty for that. And so it's pushing providers, physicians, to try and reduce costs and to think creatively about ways to do that. So this starts out as a 4% and then moves up to 9% and stays that way thereafter, after 4 years. And this is a cut to all their Medicare Part B payments. Now the good news on that is for every downside, there's a potential upside. So the highest performing providers could get a bonus and the lowest performing will be penalized. So this is a huge change for us in our community. Again, just to kind of point out that this is what we're worried about, is the loss of funds. But if we want to look at the bright side, there could be potential new funds for those highest performing physicians. And there's a scaling factor that means that they could be making additional dollars. So, yes.
Maybe it goes back to the hospital, but can you give me just a kind of a guesstimate? What does 1% represent dollar-wise?
I've been trying to estimate what that would be. When I looked at just the Medicare Part B payments made from Gillespie County residents to healthcare in the U.S., when I ran kind of what would 9% cut to all those Medicare Part B be, it just depends. It's probably in the $3 million per year range what that 9% cut would be year over year. And that's just for Gillespie County residents. It doesn't include the contiguous area. Because as you know, 48% of our patients come from Gillespie County. The majority come from outside of Gillespie County, the small majority.
Does the other outside counties have a different rate then?
Right. Well, no, I didn't include those dollars of so it would probably be about double that since about half of our business comes from this county. So it's probably $6 million impact of Medicare Part B.
Only half of our business?
Comes from Gillespie County.
I find that almost shocking.
JP?
Is this program the same as our program in the sense that what happens in 2016 impacts me in 2017 or 18?
Yes,
Exactly. It's the 2-year hop?
Yes,
Okay.
Thank you for asking that. So for the physicians, starting in January of this 2017, their performance will determine how they're paid in 2019, all year long. So they'll have 4% of their payments cut in 2019 or 4% bonus in 2019 based on how they did this year. Thank you for clarifying, Dave.
And the 501A docs, does that, it affects them directly or is it affecting us as a hospital corporation?
It affects the doctors. Well, it would be, we're the ones who get paid by Medicare for those doctors, and so how it affects them directly is based on contracting.
So does that mean that would be smart, I mean, that doctors are gonna really be put in a position to not necessarily take care of people who are, who are Medicare with more problems? And like if they have a really full practice or something like that, they may choose to,
Fire you.
yes.
Yeah, well, essentially.
There's some talk about what this means. Essentially what I'm seeing in kind of the healthcare landscape is that with some changes in legislation, the cost of healthcare for both the federal government and for insurance companies is becoming something that they don't know how to sustain for whatever reason. And probably shouldn't get into whatever that reason is. And so based on that, they're looking at how do we put more of the onus to reduce the cost of healthcare on other people and have them partner with us, have them own it more so that we're all working together to reduce healthcare costs. And so if the healthcare provider, if the doctor is somehow incentivized to reduce healthcare costs, that's probably the biggest impact on it. And I think there's some good things and some bad things in that. We see in some counties that there's over-referral, overuse of specialty, over-procedures, over-testing, things like that. So I think there's a positive in reducing that. It does make us think about patients at risk, who would be patients who tend to be higher cost to the healthcare system. So there's more push on healthcare systems to run cheaper. But there's also a lot more pressure on patients, which you've probably experienced. Deductibles are going up, co-pays are going up. We're bearing more of the risk. And part of that is to reduce the cost, but part of that is to make us more savvy as consumers about, I want to spend less on this. Insurance isn't buffering me anymore. And so everybody's now involved in trying to reduce the cost of healthcare. Okay. So that kind of summarizes what we see. Payers are moving towards shared savings, reducing costs, rewarding low-cost providers. Insurance companies are going to doctors and saying, your patients cost us this much last year. If they cost us less than that next year, we'll share half of that back to you, whatever the cost was. So if they cost $1,000 last year, this year they cost $900, we'll give you $50 free. So that's the kind of arrangements that are happening. Payment models are shifting to a set fee per procedure or per person per year, and everybody's motivated to look for the lowest cost healthcare. While there still are some quality components in there as well, which is helpful.
Is a set fee what you mean by bundling?
Yes.
Okay, all right.
Yeah, people do call it bundling. So in all of this, there's some real pressure on rural in particular. In the last few years, urban hospitals have had a 7% net gain, rural is 6% loss. We're up to 76 at least rural hospitals that have closed since 2010, most in the South, in states who haven't expanded Medicaid, which is us, and PPS, which is us. We're not a critical access hospital. I found this interesting. 69% of rural hospitals are operating at a loss. They're losing money every year. We are not at this point. We've got a tiny little margin, but most are operating at a loss. They anticipate 25% of rural hospitals will close by 2020. Now, I had thought about that, but I hadn't really thought about the implication of healthcare deserts. And that's where patients have to go long distances to get care. And I know this community thought about that when they started the hospital, so that people could get, if they're having a heart attack, get to a local ER. But the other thing I hadn't really thought about was the impact on the economy, that healthcare is generally the backbone of a rural economy. If the hospital closes and the physicians don't have a place to practice, then they're leaving town. That's a lot of jobs in a rural economy. And so property values decline, people leave town when healthcare leaves town. So there's a special kind of pressure on what are we going to do in a rural setting to stay sustainable. Because I think particularly rural doesn't have some of those economies of scale. They don't have all those big, they have just a few beds and just a few patients paying for services, but they still have to have that whole quality reporting department and the HR department and the billing department and all these different services that at a larger hospital would probably be spread over more people. So the other thing is the physician risk, and that's the new thing this year, is that our doctors being at risk. And in the hospital, we're kind of used to red tape and checking boxes and quality data and managing and reporting and turning stuff in. These physician practices are this one doctor who went and got his wife and started a business, and they're running it, and so they provide great quality health care, but aren't as familiar with all this kind of government paperwork that we're used to. So I think locally there's some risk there. How do we support our physicians, not just the ones employed by us, but if they go out of business, we all suffer. As a community, as a hospital, we want them to stay in business and to be successful. And I don't think most of them have a 9% margin at this point in time. So if they had a 9% penalty, that would be pretty hard for them to stay in operation. Okay, so opportunities. Here's the good news. My role, and Linda mentioned that it changed recently, has shifted to focus on these three things. And first is value-based payment, so expanding our knowledge of it and maximizing opportunities. Because as I mentioned, for most of these programs, there is a bonus. There is the scary penalty, but there's a bonus. So what if we as a community all worked together successfully and had new federal money coming into this community to support healthcare and support the economy? And so how can we maximize that? And coaching to achieve full dollar potential. So right now, for example, we have a group every month that comes in here of, it's now 7 different physician practices that aren't owned by the hospital. 2 are owned by the hospital, the rest are independent from all over Gillespie County and one in Blanco County. And we help educate them on this and have some processes and tools and things like that that we're all working on so that those primary care practices can be successful and stay operational in this new change. Growth. We need to make sure that we have enough people so that we're not so expensive. We have to reduce costs by having more people served. And so we have to think about, we need to serve Gillespie County, we need to serve Gillespie County better. We also need to prevent competitors from coming into our contiguous counties and really lock down the market, make sure that we are growing and staying and serving in the right areas, and developing infrastructure to do that well. And then finally, community health. I think community health is so aligned with our vision, which is empower others, create healthy. And it also is a good long-term strategy because as we as an organization, we as consumers have to pay for our own healthcare costs more and the community's healthcare costs, it will benefit us all the healthier this community is. Mm-hmm. There will be fewer amputations because of diabetes, fewer problems and complications of chronic disease. So if we can start now to develop a healthier community, we will not only have the benefit of a healthy community, which there's so many great things about that, but we'll also have lower healthcare costs, which will help us.
It's kind of like a wellness program for the community.
Yeah.
Like they did with us.
And Emily, would you speak to the growth and maybe a little bit about how we are making that happen, maybe through our business development? Or so, you know, we talked about y'all coaching under value-based payment, and then under growth, we certainly have a plan.
Yes, we do. And what we're looking at is how do we grow services in people's, really where people want the services. And more we see people wanting services in their home, not in a brick and mortar location. So we're really working on what is our plan around growth to services in people's homes. And also in those outlying communities, maybe there are some buildings that we place in those outlying communities so they're not driving down the windy roads all the way to Fredericksburg to get services unless they really need hospital care for that service. So we do have some, a lot of things happening in business development, reaching out and growing us.
Thank you.
All right, and then community health, a good example, well, I think I have one in here. So the thing I want to point out is that the physician practices, this is how they're going to be bonused or penalized in the years ahead. And this is how the hospital is being bonused and penalized. And what I see is they're very similar. And so a great thing about this is that we already have the competency in this as HCM, and so we can easily help the physician practices to get used to this and to be successful. And so that's a great advantage that we have because we've been doing this for a long time. The other good advantage that we have, and the main thing for you to see on this chart is that when you look at patients who had to use the hospital, they cost Medicare on average at our hospital $18,500, And in Texas, that same patient on average costs $21,000, about $500. So we are lower cost healthcare than the Texas and the national average here at HCM. And the main reason for that is not necessarily because we're so cheap. The reason is we provide really good care on the front end, and we see people with fewer complications and fewer readmissions. And so in the long run, it's a lower cost. And so that is really good news. If a physician or a consumer or an insurance company is looking for what's the lowest cost healthcare in the region, we're certainly that, and for many, many miles. You can also look at how much does it cost to take care of one Medicare patient per year in Gillespie County. And for us, that's about $7,000 for a Gillespie County patient. Also low cost compared to Texas and national averages. So an attractive county, an attractive healthcare organization to anyone who's price shopping. So it's a great advantage. And then our growth strategy, I spoke to this a little bit already, but if we really are providing great care, which we strive to do every day with our mission of Remarkable Always, then it is a benefit to those outlying communities if we can expand and provide it in those communities. So this is a good opportunity for us to serve more people. It's not just let's grow and get dollars. This is let's grow and serve more people with remarkable health care because we like our neighbors too and we want to take care of them as well. So one way that we're addressing community health is through the Salute for You program, where we partnered with local businesses and we go in and meet with their low-income employees. We do an entire, what we got from Cooper Clinic, which was a Fortune 500 company executive screening, all-day panel of here's all the tests that really give you a good handle on your health. And then we give that report to the patients in a way that they can look at and understand. And Kim, our dietitian, walks through it with all of them and explains, here's where your health is at, and then teaches them one change that they can make, a dietary change that they can make to start to improve that. What we learned about ourselves as an organization is we're a little bit obsessed with our numbers. How are we performing on this and that or the other? What is our number for that? And we thought, what if patients are the same way? What if they're not going to make a change if you just say you should eat healthier? But instead we said, here's your numbers. Now here's the change you could make. And we're seeing incredible whole families losing lots of weight, getting a lot healthier, just big changes. And the other benefit, and we've served about 600 people so far in our community through that program. They get a 1-year subscription to the Wellness Center for free, and they are utilizing it and having a lot of fun in Zumba primarily, I understand. But it's a great innovation, it's a great partnership with local businesses, and we've gotten grant dollars for it from the federal government. So it's new money for the community to help us get healthier. So the more we can innovate and find those grants, find those new dollars, we can improve our position as an economy. So that's kind of it on that. The other opportunity is emerging careers that we're seeing in healthcare, for your awareness, in all of this. One is a patient care coordinator. We have a couple of those right now. They help manage patients, connect them to resources. What we're finding is you can save a lot of dollars if you just make sure the patient gets their medications or figures out how to do that, or remembers to take them, or weighs themselves every day, or tries on, this is a fun one, tries on their Sunday shoes every day to see if the shoes still fit, or if they have a problem with their CHF acting up. ICD-10 coder. So one of the things is that we get, if our patients look like they should have been healthier than they were based on how we documented in the computer, then we get paid less. So we want to make sure that we document all the problems that patients have, all the diagnoses, and so ICD-10 coders make sure that we get all the payment that we're supposed to have. A patient advocate or navigator, this is usually a licensed professional, and they really focus on making sure people stay healthy. Clinical documentation specialists works on making sure we have all the right documents and they're coordinated with each other. We're seeing more medical scribes, so the electronic health record is not as easy to navigate as we had hoped. I keep waiting for Apple to come out with one because I think it'll be a lot better. I don't think they will. So what we're seeing is more physicians are just dictating to a person who's typing into the electronic record, and so that's called a scribe. And then a lot more focus, Chief Experience Officer, Patient Experience Director. That's someone who works on making sure that we're customer friendly, that we're taking good care of our patients, that they have a great hospital experience, which affects their health care and affects our payment. A lot of payment is based on patients' experiences in the hospital. But the other thing is, I heard such an interesting study. They found that there was the strongest indicator of a patient's likelihood to take their diabetes medicine was if they felt like their doctor liked them. So it's not just a soft skill thing that we want to make people feel happy and fluffy, that this actually improves healthcare if patients have a positive healthcare experience. And then Chief Population Health, someone working on what is our plan to make our community healthier and improve the health of everyone. So those are some emerging things that we're seeing in the field coming out of all of this. We're beginning to think more and more as an organization of how are we equipping our staff inside these walls to be also prepared to serve people outside these walls, out in their homes, out in the community, out where they live, because less and less the hospital will be kind of the center of healthcare, and more it'll be patients' homes. And so how do we prepare ourselves as leaders? How do we prepare payment structure? How do we prepare our staff so that we're ready and we can kind of move with agility to be prepared for that?
You are young. Do you envision in the future that you've used a lot the word hospital, that it will be replaced by a word that preventive center or something that will develop, because the word hospital is kind of ouch, you know.
Mm-hmm. It's going to be
From
last
a
resort.
insurance place and all that someday we will move on, just as we've moved on from the cafeteria and whatever.
That's a good thought, yes. And unfortunately, everyone who knows me knows I'm too wordy. So I landed on 3 words at one point, and I got an integrated health continuum. So I think the hospital will always be the heart of who we are. This is where we came from. This is what started us. So it'll be our heart, our emotional center. It'll be there when you need it kind of place for those patients that are sickest. But it will be part of a thriving, integrated health continuum. Not a health care continuum, but a health continuum. And it's continuum in that it's almost seamless that you see your doctor, it's connected with your home care, it's connected. And so that's the vision. And we're not there yet by far, but this whole, and I think I have, let's see, yeah, I do. There it is. So there's the hospital, and on any given day, the people that call themselves patients of Hill Country Memorial that day, who got a service from us that day, of those people, 7% spent the night in a bed here. 93% got an outpatient surgery, an outpatient treatment, were in our hospice or home care program, went to the wound clinic, saw their doctor. And this doesn't even include the wellness center. We have a WIC program too, women, infants, and children, so providing food for young families. And so this focus, we have all of these services, our founders and our history has been so rich. These have all been put into place. We come into a fully loaded health continuum here. And so really maximizing the fact that we already own all of this, and then we're beginning to partner for the rest of it and build those really strong relationships so that healthcare, at least in Gillespie County, we want it to be a very seamless experience that across the whole system, that we're all working together, providing that really high quality care and holding each other accountable to that on behalf of our community. So we have some good ways to go on this. Historically, we've really focused on the hospital, and that's been our focus, is how do we make the hospital better? How do we advertise the hospital? How do we make hire to the hospital? And so we're beginning to expand our thinking not only beyond hospital, but to all these other environments of care, but also to other neighborhoods and other places that aren't just the Fredericksburg area, but a little bit bigger thinking. And so we've thought like that for a long time. We're just putting some more infrastructure behind it at this point. So that is it.
Good.
Any other questions or comments? Okay, thank you.
Thank you, Emily. We appreciate you very much.
more, well, we actually gonna have some more, but, our next one is gonna be August 4th, and it's gonna be fun. Jan in the back, one of our newer volunteers, she is gonna be teaching our students as well as anyone else who wants to know about first impressions and about some soft skills you might need when you're looking for a job, and some other things having to do with that that are somewhat directed toward the students, but we can all learn something from that. And even people who have grandchildren might want to say, all right, guess what I learned? You know, or to our own children, or whatever the case may be. So that'll be August 4th, and then coming in September, we're hoping to have someone come in. My expectation is to have someone come in and talk to us about biofeedback. And we don't know a whole lot about biofeedback sometimes, but we're going to learn about that also. So those are the things that are coming up. So thank you for being here. Be sure to sign in because that goes towards your wellness if you're an employee, and we just like to keep track if you are a student or a regular volunteer. Thanks again to Emily.
Yeah.
And
Thank you, Emily.
See you later.
Hi.
Are you waiting?
Did you, well,
So, yeah, there we go, we'll keep that.
okay.
Love it.